Bismillahirrahmanirrahim. Welcome to the part 2 of lecture on allergic contact dermatitis. So you all know it's a big chapter, so it could not be completed in just one setting. So this is the second part. So let's start. We will start from the specific allergens which are important in allergic contact dermatitis. Nickel. Nickel allergy is the commonest cause of allergic contact dermatitis. It is characterized by an itchy rash that appear where your skin touches a usually harmless substance. It may take repeated or prolonged exposure to items containing nickel to develop nickel allergy. And once you develop a nickel allergy, however, you will always be sensitive to the metal and need to avoid the contact. That means once a nickel allergy, it will always be the nickel allergy. Common items that may expose you to nickel include jewelry for body piercing, rings, bracelets, necklace, and jewelry clasps, watch bands, clothing fasteners such as zippers, eyeglass frame, coins, e-cigarettes, metal tools, cell phone, keys, military dog tag IDs, chalk, medical devices, laptops. So almost everything that contain a metal is containing nickel. So this allergen has a vast range, a very vast range. Factors that increase risk of nickel allergy include ear and body piercing. Those individuals who go for frequently body piercing are more exposed to nickel allergen. Working with metals. These people may include the bartenders, people who are working in certain food industry, domestic cleaners, metal workers, tailors, and hairdressers. Then female. Overweight women seem to have an ever higher risk of nickel allergy. Then this nickel allergy is also transmitted familial through the families, and it is associated with allergy to other metals as well. Prevention. Avoid prolonged exposure to items containing nickel. First of all, you
Sorry,
should
sir,
know.
interruption.
जी? नहीं मुझे समझ आया क्या कहा आपने. आवाज नहीं आ रही, क्या हुआ? आपको मेरी आवाज आ रही है?
Yes, sir.
अच्छा. Prevention. Avoid
Yes,
prolonged.
sir.
Okay. Avoid prolonged exposure to items containing nickel. And you see why this allergic contact dermatitis is important, because not only you should be aware of the allergens, common allergens that cause allergic contact dermatitis, but you should be generally aware of the things in which these allergens are present. So you should be well aware that what are the items that contain nickel and what would be the advice that should be given to the patients with nickel allergy. However, it is not always easy to avoid nickel because it is present in so many products. The following tips may help you avoid nickel exposure. Wear hypoallergic jewelry. What is the hypoallergic jewelry? It is comprising of stainless steel. There is quite a new trend of using this stainless steel jewelry. Titanium, 18 karat yellow gold, or nickel-free yellow gold, and sterling silver. If there is a gold, sometimes you develop allergy to some gold jewelry, and it is that jewelry which contain less than 18 karat gold. And whenever there is a mixing in gold, it will be by nickel. So such kind of gold jewelry can cause allergy because of the nickel content. Silver does not have any allergic potential, so it can also cause allergy. Use the substitute material. Look for the safer substitute for common nickel containing items like watch band made of leather, cloth or plastic, zippers or clothing fasteners made of plastic and coated metals, plastic and titanium ear eyeglasses frames, then use of barrier creams. You have to be exposed to nickel at work. You have to be exposed to nickel at work, then wear gloves. And try covering buttons, snaps, zipper, tool handles, and duct tape, or wear clear barriers such as which are called as nickel guards. There are different kind of moisturizing creams which are labeled as the barrier creams because of their specific contents, structure, due to which the allergens are hard to penetrate. Then a related metal which is cobalt. Cobalt is a metal that is commonly found in soil and seawater, as well as in various industrial compounds. It is usually found in association with other metals like nickel. So the cobalt allergy is many a time is
सर सॉरी, आपकी आवाज़ नहीं आ रही प्लीज़।
अच्छा, अभी ठीक है? Now आवाज, my voice is clear?
Yes, sir.
जी सर, अभी आ रही है।
Again, and joining back,
Yes, sir.
Yes, sir. Yes,
back
sir.
to the lecture, cobalt. Cobalt is a metal that is commonly found in soil and seawater, as well as in various industrial compounds. And it is usually found in association with nickel. So many a times nickel and cobalt allergy is together. Individuals of non-Caucasian origin are at higher risk of cobalt allergy. This is some genetic basis of this allergy. What are the sources of cobalt? Cobalt is found in color glass, in porcelain, in ceramics, in pottery, and in enamel, in green and blue watercolors and crayons, in metal plated buckles and buttons, in cutting tools, machine parts, in cement, and in rubber tires. So cobalt also have a wide range of substances in which the cobalt is seen. What are the symptoms? Allergic reaction of cobalt may include allergic contact dermatitis, although irritant contact dermatitis also occur frequently. A few cases of cobalt allergy, the administration of vitamin B12 injection also causes redness, tenderness, and pruritus at the injection site. So B12 aggravates the cobalt allergy. Cobalt allergy is also found to coexist with nickel allergy in many people. Thus, the objects that cause cobalt allergy are also found to contain nickel. Cobalt allergy is usually diagnosed by patch testing, usually 2% cobalt chloride in aqueous solution, and this testing must always include nickel as well. Usually the symptoms of all the allergic contact dermatitis are the same, and so is the treatment. Treatment of allergic dermatitis include local emollients, topical steroids, and treatment of secondary infection, if any. Avoidance include the use of plastic and wooden handles of metallic instruments, then rubber gloves, then coating the items with multiple layer of clean, clear nail polish that will also be protective, and no touch technique wherever.
मुझे लग रहा है कि सिग्नल तो कोई मसला है।
Sorry for regular interruptions. So now the third metal which I'm going to discuss today is chromium. So chromium is found in leather, in cement, and other sources of in the immediate household environment. Chromate 3 ions, which is used in tanning of leather, has been identified in 95% of the leather footwear products at a concentration ranging from 0.3 to 3%, with a median content of 1.7%. So chromate or chromium. Chromium is the main metal which is found in leather and cement. Household and detergent items also often contain chromium, but they are not considered to be risk factor for chromium allergy. The most likely cause of chromium allergy is contact with metal items such as jewelry and in metal screws and in fittings. Symptoms. Chromium allergy usually manifests as contact dermatitis. But in sensitive individuals, chromium containing metal prosthetic devices may cause pain, allergic contact dermatitis, and late urticarial bullous or vasculitic reaction. So chromium is also content of the prosthetic devices. The frequent occurrence of hip pain in patients who have undergone hip replacement may point to another long-term complication of chromium allergy, namely loosening of the implants. So, since chromium is present in implant in those individuals who are sensitive to chromium, they should be identified first before going for a metal prosthetic device. And the complication which is explained here is because of chromium allergy, the device may get loosened from their site of implant. The diagnosis of chromium allergy is again based on patch testing using 0.5% potassium dichromate. Treatment is similar emollients, steroids, and treatment of secondary infection. Cessation of exposure or methods to prevent the skin contact. These include use of vinyl or rubber gloves and other protective clothing as desired, like fixing wooden or rubber handles onto the metal objects or coating small objects with few layers of clear nail polish. Fragrance mix allergy. Fragrance was declared as contact allergen of the year for 2007 by American Contact Dermatitis Society. More than 5,000 different fragrances that are in use today. In one product, the number of fragrances can be many. Fortunately, only a small number of fragrances causes allergy in sensitive individuals. Fragrance mix is a mixture of 8 individual fragrances that are used to screen for fragrance allergy. The 8 listed are the most common allergy causing fragrance and are used across many products for their fragrant and flavoring properties. You should be aware that after nickel, fragrance mix is the second commonest cause of allergic contact dermatitis. These are the different kind of fragrances mix: cinnamic alcohol, cinnamic aldehyde, eugenol, isoeugenol, geraniol, alpha amyl cinnamic alcohol, hydroxy citronellal, and Oxbos absolute. These are the 8 allergens which are present in fragrance mix. You don't have to remember the names of each of these 8 fragrances. Just remember 1 or 2, like cinnamic alcohol, eugenol, which are easy to remember. Fragrances may also be found in the workplace. Paints, cutting fluids, metal working fluids may contain fragrances to mask the offending odor. Fragrances may also be circulated through air conditioning. type of skin reactions to fragrance mist. Typical allergic contact dermatitis reaction occur characteristically on the eyelids, face, hands, and arms. There may be intense swelling or redness of the affected areas within a few hours of the rash, or may develop after a day or two of the product being used. But initially, there could be redness and swelling, and later on dermatitis. Oral exposure may cause sore mouth or tongue and rash of the lips and angle of the mouth. Sensitivity to a perfume. A positive patch test to fragrance mix indicate that you are allergic to one or more fragrance chemicals. An estimated 1 to 2% of general population is allergic to fragrance. It's a big percentage. Open application test should be done only with products that are designed to stay on the skin, such as cosmetics and lotion. Apply a small amount, 50 cent size area of the product on a small area of the skin, such as bend of your arm or neck, for several days in a row. Examine the area each day, and if no reaction occurred, it means the patient is non-allergic to that cosmetic or lotion. We advise our patients frequently to perform this open patch test or open application test. So just remember this, that you are going to ask the patient to apply the cosmetic or lotion on an area which is 50 cent size and have to done daily for several days. It won't be applicable if it is done once. Products such as shampoos, conditioners, soaps, and cleansers should not be tested in this way, as they frequently cause an irritant dermatitis if they are covered or overused on tender areas. So for this open application test, only use lotions or creams, not even volatile substances like perfumes. Once the dermatitis appear on the skin, same treatment as applied to other acute dermatitis. Prevention. Avoid all products that contain fragrance of any sort. Unfortunately, fragrance allergy is usually lifelong and get worse with continued exposure. Often products are labeled as containing fragrance and do not identify the individual chemicals used to make up the fragrance. You should avoid all products that are labeled with any of the following names. The products labeled as fragrance-free or unscented may not necessarily mean that they do not contain fragrance. They may possibly contain masking fragrance. So even if the product is not smelling, even then, because of the masking fragrances, they can cause allergic contact reactions. Note that clothes washed with scented laundry detergents can also be a problem with prolonged skin contact of the garments in presence of moisture and heat, like sweating. It would be best to use fragrance-free laundry detergents. Then another common cause of allergic contact dermatitis is topical medication. Topical medications include balms, creams, gels, oil, lotion, patches, ointments, or any other product with medicinal ingredient that is applied to the skin. Topical medication is made up of an active ingredient and base, which may contain preservatives and fragrances. Many products such as antibacterial and antifungal preparations, anti-inflammatory and pain relief preparations, and cleansing and moisturizing agents are responsible for allergic contact dermatitis. So how the allergy sets in for medication. Such medications, when applied, can result in contact urticaria, resulting in local burning sensation, tingling, and itching within 1 hour. Anaphylaxis can occur, resulting in difficulty in breathing and nausea, vomiting, and acute urticaria and angioedema. Then irritant contact dermatitis. In 80% of all cases of contact dermatitis, people with atopy are more predisposed, and strong irritants reaction can occur within minutes. Allergic contact dermatitis can occur in patients whose immune system is sensitized to that allergen. Then photosensitivity may also occur due to medicinal ingredients. What are the allergens that commonly cause allergy in topical medication? Neomycin. So all the antibacterial creams containing neomycin can cause allergy. Usually the creams containing neomycins are labeled as N, like Betnovate N, Cloviderm N. So all these N containing creams, they contain even the Polyflex contain neomycin. Then corticosteroids, which are used for the treatment of allergy, can also result in allergic contact dermatitis, especially if it is found in combination with antibacterial and antifungal creams. Benzocaine, which is used in local anesthesia, topically and mucosal surfaces as mouthwashes and some hemorrhoidal preparation. Salicylates used in muscle pain creams. NSAIDs, topical NSAIDs. So sometimes the allergy due to medicines are not because of the active ingredient, but because of the fragrances and preservatives. Diagnosis. Allergy to topical medications is diagnosed by performing patch tests. It appears that allergy to topical medications is most common in elderly people, that is more than 70 years of age. And it is common in individuals with venous stasis dermatitis. Patients with otitis externa are often allergic to topical neomycin and topical corticosteroids. Treatment. Contact dermatitis should clear rapidly once the offending allergen is removed. And when the allergen is not a topical steroid, then hydrocortisone can be given to control itching and swelling and redness. And in cases it is due to steroid, then use a highly potent steroid for treatment. Care is needed when prescribing topical medications to elderly patients with eczema, especially preparations that contain perfumes, lanolins, these are bases, and local anesthesia. So avoid neomycin and avoid those neomycin that contains lignocaine, like Helit ointment and Polyflex plus cream. So you can easily prescribe them Fusidin or Mupirocin. Cosmetics, a big group causing allergic contact dermatitis. Cosmetic is defined as topically applied product that is used to beautify, cleanse, or protect the hairs, skin, teeth, or complexion. So in this definition, almost all the cosmetics are covered. Division of cosmetics and drugs is not always clear, as there are many products available that have two intended use. For example, an anti-dandruff shampoo. It is both a medication as well as a cosmetic. Cosmetics can be broadly divided into the following groups. Facial makeup, like eye makeup, lipstick, blushes, foundations, nail cares, varnishes, removers, artificial nails, skin care, cleanser, moisturizers, toners, hair care, shampoos, hair color, dyes, regrowth treatment, oral care, toothpaste, mouthwashes, body cleansers, soap, bath additives, shower gel, shaving foam, cream, aftershave lotion, fragrances and perfume, deodorants, antiperspirants, and sunscreen. So almost everything which we use as cosmetic can cause allergy. Incidence. It is estimated that on average, women are using 7 types of cosmetic each day, and reaction to these products are quite common. You can see among these chemicals, it is said that at least 7 of these chemicals are exposed to every woman every day. Several studies suggest that up to 10% of the population will have some type of reaction to a cosmetic through a lifetime. The figures may be much higher as mild reactions occur at home and are self-diagnosed and often self-treated. Like
ब्रेक हो रही है
क्या हुआ? So, just like the medicamental allergic contact dermatitis, cosmetics can cause contact urticaria. They can cause anaphylaxis. They can cause irritant contact as well as allergic contact, and they can cause photocontact dermatitis. Allergens in cosmetics. Fragrances. There are more than 5,000 different fragrances used in cosmetics and skincare products. They are present in most types of cosmetics, including perfumes, shampoos, conditioners, moisturizers, facial cosmetics, and deodorants. 70 to 90% of fragrance allergy can be picked up by patch testing with fragrance mix and balsam of Peru. Cosmetics labeled unscented does not mean fragrance-free. Some unscented products may contain a fragrance to mask the other chemical odor. Products should be labeled fragrance-free or without perfume to indicate no fragrance is used. So rather than using the word unscented, the cosmetic manufacturer should use the word fragrance-free or without perfume to indicate that these cosmetics are free from the perfume. So one of the cause of cosmetic allergy is fragrance, then preservatives. Preservatives are the second most common cause of contact allergy due to cosmetics. Cosmetics contain water, have a preservative in them to prevent bacterial or fungal growth. Some of the preservatives most commonly found in cosmetics include the parabens, formaldehyde, imidazolidinyl urea, then isothiazolinone. These are the different preservatives which are used in cosmetics. You don't have to remember the name, of course, but remember that what are the causes, what are the main ingredients causing cosmetic allergy. Then paraphenyl diamine in hair dye. This is again a very common allergy which we come across. PPD is the third most common ingredient after fragrance and preservatives to cause allergic contact dermatitis. It is widely used in permanent hair dyes because it results in a natural color. Reaction to PPD may be mild and involve dermatitis to upper eyelids and rim of the ears and may be more severe with swelling of scalp and face more white. New derivatives of PPD have low risk of causing the allergy. This PPD is actually the ammonia which is used by the layman as a cause of hair dye. Other allergens which are used in cosmetics and which can cause allergy allergic contact dermatitis are these: lanolin, coconut dye, ethanolamide, the different chemicals. Of course, we are not going into the details. Cosmetic allergy is diagnosed by performing a patch test or an open application test, which I told you while dealing with these medicines. Treatment and prevention. Contact dermatitis should clear rapidly once the cosmetic allergy is removed. Mild topical steroids or emollients may be used. Prevention. Best way to prevent contact allergy to cosmetic is to avoid all products that contain the allergen. Read the list of ingredients on all cosmetic products to identify if they contain the relevant allergens. So this can only be done by use of patch testing. And once we find that what are the different chemicals which are causing allergy, positive in patch test, then the consumers would do this, that they would see the contents of the cosmetic and avoid those cosmetics contain that peculiar allergen. Test new cosmetic, placing a small sample of product or inner waist or elbow and observe for 24 to 48 hours. Choose products with few ingredients rather than the products with many ingredients which have more potential to cause allergy. Use the products with fewer ingredients. Apply perfume to clothing rather than on the skin and allow the perfume to dry before putting on the clothes. This is applicable to all those individuals having perfume allergy. Look for the products that are hypoallergic, fragrance-free, and non-comedogenic. However, be aware that these still may cause reactions. Formaldehydes. Formaldehydes are not only sensitizers, but also a potent primary irritant. That means it can cause both irritant and allergic contact dermatitis. Exposure to formaldehyde gas may cause burning sensation in eyes, nose, throat, skin rashes, tightness of chest, wheezing, fatigue, and headache. So all the signs of anaphylaxis are seen by inhaling the formaldehyde gases. Frequent or prolonged exposure may cause hypersensitivity, leading to development of allergic contact dermatitis. Allergy to formaldehyde may occur through skin formaldehyde containing products or with clothing made from fabric which is treated with formaldehyde. Sweating may be a cofactor as sweat and sebum appear to leach free the formaldehyde from formaldehyde resins. Clothing dermatitis is reported to affect more women than men. These are the different sources of formaldehyde: fluid and hydrotic or antiperspirants, building materials. This is the most important. The clothing made from the fabric finished with formaldehyde resins. Formaldehyde allergy is diagnosed from clinical history and by patch testing using 10% urea formaldehyde in petrolatum. Self-testing a product of formaldehyde should be done only with products that are designed to stay on the skin. That means lotions or creams. If you are diagnosed with formaldehyde allergy, it is best to avoid the formaldehyde containing products. Treatment is as for any other dermatitis. It is difficult to avoid all exposure to formaldehyde because it is normally present in low concentration, that is less than 0.03 part per million in both indoor and outdoor air. So most patients, low level of exposure, that is less than 0.1 part per million, does not cause any problem. Rubber. Rubber compound is obtained by mixing a base polymer with a series of additives. So it has two contents, a base polymer and additives. the resulting product is non-vulcanized compound. The most common additives are fillers. Two types of fillers which are used in rubber: reinforcing and non-reinforcing fillers. Carbon black is the commonly used reinforcing filler. That is why most of the rubber are black in color. Calcium carbonate is an example of non-reinforcing filler. Sources of rubber: rubber gloves, balloons, rubber grip pens, hair brushes, cooking utensils, grips on exercise equipment, mouse or computer wrist pads, undergarments, socks, rubber bands, shower caps, etc. There's a large number of chemicals that ingredients that contain rubber. So allergic contact dermatitis due to rubber can be divided into two main categories: allergy to latex, which is the raw rubber compound, which is a base polymer, or to the chemical accelerators and antioxidants added to the rubber during the processing and manufacturing. These include serums, mercaptobenzothiazolate, thioureas, and carbamates, which are all rubber or accelerators that can cause sensitization. Rubber antioxidant is paraphenylene diamine. Characteristic finding on physical examination. Latex allergy can physically manifest as erythema, pruritus, eyes, and later chronic eczema. If mucosal surfaces are exposed, angioedema can develop. Other reactions are sneezing, itchy eyes, asthma, throat discomfort, and anaphylaxis. A delayed type reaction to non-latex rubber accelerators would, in acute phase, manifest most commonly as erythema, pruritus, and vesicle in area of exposure. In chronic phase, it is characterized by erythema, scaling, fissuring, and hyperkeratosis. So in chronic acute phase, it is mainly urticarial reaction. In chronic phase, it is mainly eczematous reaction. It is important to note that eruption usually starts 24 to 48 hours after exposure. What are the different diagnostic studies done to pick up rubber allergies? Radioallergosorbent immunoassay, which is called as RAST assay. It quantifies the latest specific IgE antibody. Then lymphocyte transformation test, used to measure the proliferation of T cells when a patient is exposed to certain allergens or sensitizers like latex. Skin prick testing this is another kind of allergic testing, in vivo test that serves as gold standard to diagnose latex allergy. A positive test is indicated by erythematous pruritic wheal developing within approximately 15 minutes. A skin prick, you just prick the skin with that allergen. Glove use test involve placing a rubber product on any one of the finger at first and then progressing it to the entire hand. Then patch testing, which we do for all the other allergies. Epidemiology and at-risk population. Incidence of latex allergy is 1 to 2% in general population. It is due to repeated exposure of their mucous membranes to latex during various surgical procedures. Why? Because the endotracheal tubes, or the other tubes which are placed in the mouth, they all contain rubber or latex. So even if the individual is not exposed to latex, if they have undergone surgeries, then they may develop latex allergy. Second population most at risk of developing latex allergy are the healthcare workers, particularly those working in operation rooms, laboratories, and ambulances. Nowadays, due to corona, there is such a high incidence of latex allergy. Latex allergy is 4 times more common in atopics than in non-atopics. Patients with certain food allergies may also predispose patients to develop a latex allergy. These food include avocado, kiwi, banana, apple, tomatoes. So these ingredients potentiate the latex allergy. Rubber accelerators or antioxidants. Patients at risk include divers due to the wetsuits, food handlers, healthcare workers, and hairdressers. Optimal therapeutic approach for latex allergy. Treatment of acute reactions. If type 1 hypersensitivity reaction occur like respiratory distress, swelling of oral cavity and anaphylaxis, then it is treated by epinephrine pen. These are the pre-filled epinephrine pen which is given to the sensitive individuals. And whenever they start developing the symptoms, they are instructed to self-inject these pens. Antihistamine should be used after stabilization of patient in acute emergency. So different anti-allergies can be used. Prednisolone, like Solocortef, is used after stabilization. So this, in such kind of distress, the first treatment is epinephrine. And then antihistamine and corticosteroids come at the third level. Then in established latex allergy, the primary treatment is avoidance of allergy and substitute latex with non-latex agents like nitrile. There are nitrile gloves which are available, neoprene gloves available, polyisoprene gloves available, then barrier creams, narrowband UVB, cyclosporine, azathioprine, mycophenolate mofetil. Consider sublingual desensitization therapy, which I'll explain later. Patient management. While desquamation for latex allergy is frequently performed, several clinical trials have evaluated sublingual subcutaneous immunotherapy protocols. Sublingual immunotherapy has better safety profile. So in this therapy, you tend to expose patients with sublingual doses of gradually increasing doses of the chemical, and the patient, since this would result in induction of cytotoxic T cell, this will indirectly influence and inhibit the latex allergy. Prevention can be divided into two main categories, primary and secondary. Primary prevention involves non-sensitized individuals in high risk group whose main goal is to avoid contact with natural rubber latex products. Other important action includes avoidance of oil-based hand cream that break down rubber, leading to faster sensitization. So directly don't apply any moisturizer directly on the hand after removing a latex glove or any latex products. First of all, wash the hands or wash the area on which the latex is applied before applying a moisturizing cream. Otherwise, the moisturizing cream would aggravate the latex allergy. Leather. Patients with this allergy are more likely allergic to dimethyl fumarate, a chemical used in leather tanning processes. Dimethyl fumarate, which is also known as DMF, is used for its antifungal property and is known to cause many skin reactions. Although the symptoms of this allergy aren't very severe, they can be painful if not treated immediately. Reactions to dimethyl fumarate. In high enough concentration, it may cause irritant contact dermatitis. In low concentration, it causes allergic contact dermatitis. The rash is often seen of back of the legs, buttocks, and back of patients who have sat on DMF contaminated couches. So nowadays, it's quite common to have leather couches in our homes. And those individuals who are sensitive to leather can develop allergic contact dermatitis while sitting on these couches, which is called as the sofa dermatitis. And continuous and repeated exposure would result in worsening of the symptoms. DMF has also been implicated in foot and shoe dermatitis. So the dermatitis is acute and sharply demarcated eczema that matched exactly to the contact area of shoe exposure. Many of you must have noticed that shoe dermatitis is so symmetrical and so clear-cutly typical of the shoe which has resulted in this dermatitis. Dimethyl fumarate was declared as contact allergen of the year 2011 by Allergic Contact Dermatitis Society. Latex allergy symptoms, leather allergy symptoms are itching, burning, rash, xerosis, peeling. Diagnosed by simple patch testing by using dimethyl fumarate in petrolatum. Alternate name of dimethyl fumarate is fumaric acid, dimethyl ester, allomalic acid, or dimethyl ester, methyl fumarate. So usually the name of fumarate is or fumaric acid will be present in all the ingredients containing dimethyl fumarate. Once DMF allergy is confirmed, then removal of causative agents and then management as of acute dermatitis. Leather allergy frequently asked question. What causes leather allergy? You know it is DMF, which is mainly used as an antifungal agent. Can leather furniture cause allergic contact dermatitis? Yes. Can socks prevent feet from allergic reaction to leather shoes? We commonly ask patients to wear cotton socks with their shoes to avoid leather allergy. Socks can protect some people from experiencing allergic reaction to leather shoes. Is leather allergy curable? Leather allergy, like other allergies, are not curable. However, some patients have reported becoming less sensitive to leather over time. Epoxy resins. We are almost at the end. Epoxy resin is a chemical that is a part of epoxy resin system. Epoxy resin systems are used in industry because of their strong adhesive property. Any of these chemicals on their own may cause irritant or allergic contact dermatitis. ये जो एलर्जी है ना समझ बॉन्ड से, एल्फी से, ये सारी इपॉक्सी रीजंस की एलर्जी. Most people associate epoxy resins with glues and adhesives. These glues come in two parts, hardeners and resins. When mixed, it is claimed that resulting compound can stick almost anything together. These are the sources of epoxy resin. All those agents which cause adhesion contain these epoxy resins. Wide range of products. Skin contact with these agents can cause burning and should be washed with soap and water if such contact and reaction occur. They are diagnosed by clinical history and performing by patch testing. Standard patch testing has epoxy resin 1% in acetone or petrolatum. Treatment. Washing area immediately with soap and water. Sometimes solvent like acetone, alcohol can be used to reduce the exposure. However, routine use of these chemicals is not recommended. The routine use of acetone and alcohol because it may irritate the skin. Dermatitis can be treated by emollients, topical steroids, or antibacterials. Prevention. When using epoxy glue at home, avoid touching the glue and breathing in the fumes. To reduce exposure, special gloves, which are nitrile rubber gloves, to protect hands. Rubber gloves do not help as the resins penetrate through the rubber gloves in 30 seconds. If you are highly sensitive to epoxy resin, be aware of the product that may contain these resins. Plants. Plant dermatitis is also called as the phytodermatitis. Is a reaction to the skin in contact with certain plants. It is not always obvious which plant is responsible for dermatitis. Sometimes a rash develops without direct contact with the plant. The juices may be on the clothing and finger that can cause contact dermatitis. A plant cause of dermatitis is suspected where there is linear or streaky pattern. So the phytodermatitis comes under the diagnosis of linear dermatosis, and it is always asymmetrical. Some plants can cause, it is symmetrical only if it is self-induced. Some plants can cause rash if sun is shining on the skin at the same time. This is called as phytophotodermatitis. Brick blisters may develop on exposed parts. Anyone can get this kind of plant dermatitis, which settles leaving pigmented patches, which may last several months. One of the dermatitis due to such kind of perfume is called as the Burlock dermatitis. A number of cases of very allergic contact dermatitis resulting in facial swelling and blistering of exposed part, which is seen every year due to some rheus tree, which is found in autumn. So the plant allergies are seasonal. Rash appear between 4 hours to 10 days after exposure to a plant, depending on the individual sensitivity and amount of contact. Sometimes more rash appears after treatment has begun due to bloodstream spread of allergens to other areas. This phenomena is called as autoeczematization, spread of eczema to different areas. Plant dermatitis is self-limiting, clears without treatment if the plant is avoided. Topical steroid may be used and is less effective when skin is blistered. Prevention. Only way to prevent plant dermatitis is to avoid the contact with responsible plant. Your dermatologist may be able to organize an allergic test. We do not use a test for reaction to most strong allergic plants because the test could themselves create new allergens. What are the commonest plant allergens? Anacardiaceae, which is oak and ivory, composite family. Then tulip and Peruvian lily, tea tree oil, fragrance like lavender, jasmine, rose, bergamot. Then oxalates, furocumarins, onion and garlic, Brassica family. So remember a few of these, which are the cause of plant dermatitis. Type of reactions, it can be an irritant contact dermatitis. Direct exposure result in sudden appearance of rash with fissuring and burning sensations. Then allergic contact dermatitis, slow to develop, rash will be eczematous, and itching will be more seen rather than burning. Then phototoxic reaction, if plant contact occur on photo-exposed areas and on top of that sunlight is exposed. This is commonly seen with furocoumarins, as in citrus juices, when exposed to sunlight. Most common allergic contact dermatitis is linear, vesicular, and pruritic on exposed areas. Extensive exposure may lead to extensive dermatitis. Irritant exposures may present with vesiculation and erythema. Chronic exposure dermatitis, hyperkeratosis, fissuring. Common findings is fingertip hyperkeratosis and fissuring. Diagnosis by appropriate history and skin examination, and diagnostic patch test is used. Nearly everyone is at risk for developing a plant dermatitis in any part of their lifetime. 70% of individuals living in endemic areas will develop allergic contact dermatitis to poison oak, poison ivy, and sumac during their lifetime. Phytophotodermatitis occur in those exposed to furocoumarin containing plants and subsequent ultraviolet exposure. Treatment options: mild with mild steroids, moderate with topical steroids, oral therapy with oral steroids and antihistamines. Considering self-limiting nature of the condition, in most cases, physical modalities such as phototherapy is not necessary. Sometimes allergic contact dermatitis result in non-eczematous rashes, like EM-like reaction. Although the targetoid lesions will be seen, but they will not be acral in distribution. Purpuric reaction can occur as allergic contact dermatitis. It is usually associated with khaki uniforms due to azo dyes which are used in textiles. Lichen planus and lichenoid reaction can also occur, especially due to the color developers, paraphenylene diamine. You see, in frequent hair dye dermatitis, patients develop lichenoid lesions at the edge of the hairline, Then lymphomatoid eruptions. Occasionally, contact dermatitis present with cutaneous lymphoma-like plaques. This is seen in those sensitive to gold. Pigmented dermatitis. Hyperpigmentation occur on covered areas with or without dermatitis in relation to topical whiteners in washing powders. Then depigmentation can occur. It is has to be distinguished from direct melanotoxic effect of certain quinones, substituted phenol, which is the common cause of occupational vitiligo. Granulomatous reaction can also occur because of reaction with zirconium and deodorants. Then onycholysis can be a presenting feature in certain allergic contact dermatitis due to nail varnish. Patch testing I will deal in a different lecture. So going to management, first and foremost is avoidance of the allergy. Detailed examination and history, then patch testing, and after patch testing, confirm the allergy and then avoid the allergy. Further advice to avoidance is protective clothing, change in handling technique of those allergens, especially if they are associated with occupational dermatitis. Then protective gloves. Specific avoidance: plastic instead of rubber gloves, cosmetic and medicament free of allergens, clothing face of nickel containing studs, zips, and other nickel containing agents. Reassessment and reinforcement to avoidance measure is often required. Active treatment include liberal use of emollients, topical steroids, soap substitutes, cover the fissures with hypoallergic tape, zinc and salicylic acid paste twice a day. For recalcitrant and disabling cases, L-tretinoin, which is a kind of retinoids which is used in chronic allergic contact dermatitis, other anti-lymphocyte agents like azathioprine, cyclosporine, superficial X-rays, bruise rays, phototherapy, UVA, UVB, and barrier creams containing chelating agents. Treatment algorithm for allergic contact dermatitis. Identify the culprit through allergic patch test, avoidance, education and preventive measure. No form of symptomatic treatment can substitute this approach. Then selection of suitable corticosteroid which is appropriately effective and with low risk of atopy, that is mometasone, methylprednisolone, Advantone or high weight with the brand names. Short wave ultraviolet B or PUVA is effective in chronic dermatitis, most commonly in hand dermatitis, because all these contact dermatitises are because of lymphocytes and phototherapy is anti-lymphocyte. Then systemic immunomodulators already discussed. In severe cases, use cyclosporin, methotrexate, azathioprine, and mycophenolate mofetil. Dietary modification, avoidance of intake of allergens like nickel and balsam, dietary chelation of nickel. Dietary measures help in cheilitis and oral symptoms. Hyposensitization. Many attempts have been made to downregulate the immune response to allergen in an already sensitized individual. The degree of hyposensitization achieved by oral doses of allergen is limited and transient. For example, DNCV and chromate and poison ivy in humans. Some success have nevertheless been claimed in India for hyposensitization against Parthenium. It is a plant called as the Gajar Ghas. Another form of hyposensitization is allergen immunotherapy or desensitization. This is what is done in National Institute of Health, Rawal Dam since years. It is a medical treatment for environmental allergens. Immunotherapy involves exposing people to larger and larger amount of allergens in attempt to change the immune system response. Meta-analysis have found that injection of allergens under the skin are effective in treatment of allergic rhinitis in children and asthma. So this therapy is mostly suitable for those patients having asthma and seasonal rhinitis and is less effective in skin allergies. Potential side effects include mild to moderate skin or respiratory reactions. Severe side effects include anaphylaxis during cutaneous immunotherapy, but it is relatively uncommon. Legal and other regulatory measures, nickel containing items should not release more than 0.5 microgram per centimeter square per week of nickel. Hexavalent chromate in cement should be restricted. So all these legal and regulatory measures are not practiced, of course, in Pakistan. Preservatives not permitted above 15 millimeter and formaldehydes above 0.2% cosmetic products. Enforce ingredients labeling on package of cosmetics. Corporate responsibility. In many instances, government will not intervene with legislature relying on self-regulation. Manufacturers of all goods should ensure that their products are safe to use. Domestically, Cotton lined gloves should be worn when hands are in contact with eaten food, cleansing agents, and polishes. Plastic gloves are less allergic than rubber gloves, and education is fast and the foremost. Then these are the two topics: photoallergic contact dermatitis and contact urticaria. These two topics I will be covering next time when I will be covering the patch testing. So already I have taken a lot of time and I've also consumed most of my energy and of course your energy. Still you have any question regarding this talk? Go ahead and ask please.
सर डॉक्टर फिजा फैसलाबाद से बात कर रही हूँ।
जी
सर मैंने पूछना था कि जो आजकल ये वाइटनिंग क्रीम्स है उनमें मर्करी का कंटेंट बहुत ज्यादा है और उसके साथ हमारे पास काफी सारे पेशेंट्स आते हैं जो कॉन्टैक्ट डर्मेटाइटिस करवा के आते हैं, तो इसके खिलाफ भी कोई मतलब कोई रेगुलेटरी या कुछ ऐसा कोई सिस्टम बना है कि जो
वाइटनिंग क्रीम के खिलाफ ना बहुत सारे सिस्टम बन चुके हैं। ये ना इसमें हेल्थ अथॉरिटीज ने भी इसके ऊपर एक्शन लिया है, लेजिस्लेशन की कोशिश भी की जा रही है और बहुत सारी ऑर्गेनाइजेशन इसके ऊपर काम भी कर रही है। एंड आई होप विद इन, क्योंकि आपको पता है पाकिस्तान में हर काम इतना मुश्किल होता है और जो वाइटनिंग क्रीम बनाने वाले जो मैन्युफैक्चरर्स हैं वो इतने स्ट्रॉन्ग हैं और काफ़ी सारे तो पॉलिटिशियंस भी हैं और इवन मेंबर ऑफ असेंबली भी हैं कि कोई भी लेजिस्लेशन पास करना आसान नहीं होगा, लेकिन एफर्ट्स आर गोइंग ऑन। यू सी, मतलब जो ये इवन गोल्डन पर्ल है, ये गोल्डन पर्ल का जो मालिक है वो मेंबर ऑफ प्रोविंशियल असेंबली है पंजाब का। तो ऐसे लेजिस्लेशन पास होना कि जिसमें जो मालिकान हैं वो लेजिस्लेटिव असेंबली में बैठे हैं, रियली वेरी डिफिकल्ट। लेकिन ये सारे मसाइल पाकिस्तान में ही होते हैं, वैसे और मुल्कों में इस तरह की हरकतें होती नहीं हैं, लेकिन पाकिस्तान में डेफिनेटली ये होता है। लेकिन बहुत सारा काम ऑलरेडी हो चुका है एंड लेट्स होप फॉर द बेस्ट इन फ्यूचर।
सर ये ना मैंने इवन हम दुबई का मेरा टूर हुआ था, एक तो मैंने उसमें चेक किया था, तो वहां पे उनके इवन जो डिपार्टमेंटल स्टोर्स है वहां भी ये स्टिलमैन्स और गोल्डन पर्ल और सारी क्रीम्स पड़ी हुई। आई वाज शॉक कि यहाँ पे भी
यूके में भी होती हैं और कुछ ऐसे पहले एक न्यूज आई थी जिसमें यूके में ये बैन की गई थी ओवर द काउंटर ये जो प्रिपरेशंस होती हैं। तो ये तो खैर एक अलग इशू है, ये एलर्जिक कॉन्टैक्ट डर्मेटाइटिस इसका कोई ताल्लुक नहीं है, क्योंकि जो रिएक्शन हम वाइटनिंग क्रीम से देखते हैं वो एलर्जिक कॉन्टैक्ट डर्मेटाइटिस से काफी ज्यादा है। वो स्किन एट्रोफी है और उसमें थिनिंग ऑफ द स्किन है, हिर्सुटिज्म है जो निकलता है, और जितना मर्करी कंटेंट यूज होता है इन क्रीम्स में वो एब्जॉर्ब होके सिस्टेमिक मर्करी पॉइजनिंग भी कर सकता है। तो दिस इज अ वेरी सेपरेट टॉपिक, not related to actually this allergic contact dermatitis, not even the cosmetic allergy.
मैं उस ये अटैक भी करता है या जस्ट ये इरिटेंट कांटेक्ट ही करता है?
ये क्रीमें आपको पता है लोग इसको बेशुमार अरसा इस्तेमाल करते हैं, तो ये क्रीमें ना जनरली एलर्जी उन्हीं को करेंगी जो सेंसिटिव होंगे। तो वो सेंसिटिव इंडिविजुअल को तो नॉर्मल निविया क्रीम भी एलर्जी कर लेगी। तो ये ना जनरली इसमें इतना सेंसिटाइजिंग पोटेंशियल नहीं है मर्करी में जितना इसके और साइड इफेक्ट टॉपिकल एंड सिस्टेमिक। तो वो जो मर्करी के जो कांटेक्ट है वो क्लासिकली इसके अंदर नहीं आती है एलर्जी कांटेक्ट में।
ठीक है सर।
एनी अदर क्वेश्चन?
थैंक यू सर।
सर जो हमारे पास फार्मर्स आते हैं मोस्टली गर्मियों में और जब हमेशा जिनकी खेती बड़ी होती है उसके बाद जब सीजन आता है तो वो ज्यादातर एग्रीवेटेड बाय सनलाइट होता है या फिर इसमें प्लांट्स का भी रोल ज्यादा होता है?
देखो वो ना मिक्स है, उसमें देखें उसमें केमिकल्स भी हैं लाइक कांटेक्ट विद फर्टिलाइजर्स, कांटेक्ट विद स्प्रेज, साथ प्लांट्स का कांटेक्ट भी है, साथ डस्ट वगैरह का कांटेक्ट भी है, साथ सन एक्सपोजर भी है। तो इट्स अ मल्टी फैक्टोरियल, क्योंकि ये जो एयरबॉर्न डर्मेटाइटिस एक बजाते खुद एक अलग शोबा है, फोटो डर्मेटाइटिस एक अलग शोबा है। तो एयर बॉर्न भी एलर्जीज होती हैं जो अभी हमने इस एलर्जिक कॉन्टैक्ट डर्मेटाइटिस में एयरबॉर्न एलर्जीज को कवर नहीं किया। तो एयरबॉर्न एलर्जीज भी होती हैं डस्ट से रिलेटेड या पोलन से रिलेटेड, और इसके अलावा ये मैं अभी फोटो एलर्जिक, ये जो पढ़ाने वाला हूँ फोटो एलर्जिक कॉन्टैक्ट डर्मेटाइटिस, इसमें भी थोड़ा जिक्र है उसका। तो इट इज मल्टीफैक्टोरियल। जो एलर्जिक कॉन्टैक्ट डर्मेटाइटिस ड्यू टू या एक्टिनिक डर्मेटाइटिस जो फार्मर्स को होता है, इट्स अ मल्टीफैक्टोरियल डिजीज, और इसमें आपको बहुत सारा, लेकिन अक्सर मसला ये होता है कि वो अपने प्रोफेशन तो छोड़ नहीं रहे होते, तो वो तो वही काम करेंगे और उनका ब्रेड एंड बटर भी वही है, तो इट्स रियली वेरी डिफिकल्ट टू कंट्रोल देम।
Sir, I have a question. Sir, जो फूड एलर्जीज होती हैं, लाइक मोस्ट ऑफ द पीपल कंप्लेन कि हम कोई खाना वगैरह खाते हैं और कुछ को तो पता ही नहीं होता कि किस चीज से एलर्जी है, एंड इट इज नॉट पॉसिबल फॉर देम टू अवॉइड सर्टेन फूड्स, लाइक वो बिल्कुल कट ऑफ तो नहीं कर सकते, तो उसमें एक्सेप्ट फॉर अवॉइडिंग सच फूड्स और कोई ट्रीटमेंट है अवेलेबल एक्सेप्ट फॉर
जो
दीज,
जो
जिस
फूड
तरह के?
एलर्जीज है ना, वो आमतौर पे हम उसको करेंगे इसमें कुछ जिस तरह ऐसे केमिकल्स जो एलर्जी कॉन्टैक्ट डर्मेटाइटिस करते हैं, वो अगर फूड में ले लिए जाएं तो वो एलर्जी एग्रेवेट कर सकते हैं। जिस तरह DNCB है, डाइनाइट्रोक्लोरोबेंजीन है, या निकल है। तो ये तो इंग्रेडिएंट्स हो गए कि जिनसे निकल डर्मेटाइटिस या DNCB रिलेटेड एलर्जी बढ़ जाए। हम फूड एलर्जीज देखते हैं यूजली अर्टिकेरिया के रेफरेंस, एक्जिमा के रेफरेंस, एक्नी के रेफरेंस, मतलब बहुत सारे ऐसे डर्मेटोसिस हैं जिनको फूड एग्रेवेट करते हैं बिकॉज ऑफ डिफरेंट रीजंस। फूड एलर्जीज को हिस्ट्री से और प्रेजेंटेशन से आप आइडेंटिफाई कर सकते हैं, लेकिन जो पेशेंट्स ये ना कर सकें तो फूड एलर्जीज के भी टेस्ट अवेलेबल हैं। आमतौर पर ये फूड एलर्जेंस के प्रिक टेस्ट होते हैं, जिस तरह NIH में भी एग का, फिश का और शायद एक आध और फूड एलर्जन का टेस्ट अवेलेबल है। AFIP हमारी आर्म फोर्सेस इंस्टीट्यूट ऑफ पैथोलॉजी जो पिंडी में है, ये भी एक बैटरी ऑफ टेस्ट ऑफर करती है टू फूड एलर्जन। इसमें मुख्तलिफ किस्म के फूड एलर्जेंस हैं जिनका स्किन प्रिक टेस्ट किया जाता है। तो फूड एलर्जेंस के भी टेस्ट अवेलेबल हैं जो बता सकते हैं कि कौन से फूड से एलर्जी। So any other question? चलो बस करते हैं जी। तो अभी नेक्स्ट वीक बाकी इसका अगला पार्ट और पैच टेस्टिंग कवर किया जाएगा और फिर इरिटेंट कॉन्टैक्ट डर्मेटाइटिस किया जाएगा। ओके, खुदा हाफिज़।